for telling anything more. You know, this is the gross appearance. You can see my cursor? No. Can you see my cursor?
Yes, sir.
Okay, okay. So this is the gross appearance. This is the superior surface, inferior surface, and it is divided into many segments and lobes anatomically and segments for surgical purposes. So we know that the liver biopsies that we take, first of all, we see mainly biopsies, needle biopsies. The first thing you must understand is that you must have good sections, and the needle biopsies, it depends on how thick you want to cut. Generally, most labs cut little lesser than 5 microns. It's not necessary, it has to be 2 or 3 microns like the kidney, where the basement membrane has to be seen very clearly. Little thick is all right. Some people cut at 5 or 6, but whatever it is, you have to be accustomed to what your lab, thickness of the section of your lab. Otherwise, you see on this side, on the left side of your screen, you will see this is a thinner section, and right side it is a thicker section. Here you will find that as if the inflammation looks a little more darker and thicker than on the what is seen in the thinner sections. So this here, they are the same. One is same biopsies cut in two different sections. Your eyes have to get used to this. It's perfectly all right, but don't cut very, very thick sections, obviously. Why do you do liver biopsies? Nowadays, it's mainly done to clarify diagnosis and how severe the liver damage is by grading and staging what we do. So, and it's used for identification of tumors, their grade, etc. And in many instances, it's used for prognostication based on the grade and stage of inflammation as well as repair and also the tumor. So therefore, these help in treatment decisions. Sometimes it's used to monitor the progression or response to treatment. You do one biopsy, you treat, later you do another biopsy. And it's also used for obtaining tissues for molecular biology nowadays, some microbiological tests and research. Okay, so diagnostic liver biopsies, especially in inflammatory diseases, chronic hepatitis B and C, because you have very good serological and microbiological tests, the number of biopsies that are done are becoming lesser and lesser. In fact, you do more biopsies for fatty liver disease, autoimmune hepatitis and all. So we'll concentrate more on those things. But we'll definitely go through all the chronic hepatitis. So you see, so, and of course, for tumors, both primary and metastatic, they do this. Okay, so the types of liver biopsies that you get, one is the needle aspiration, which is very common. It's mainly percutaneous and blind. Sometimes it is image guided, especially for tumors. But generally, inflammatory diseases, a lot of people don't use image guidance, although sometimes if radiologists do it, they would prefer a ultrasound guided needle. Then once you're doing a laparoscopy, you can do a punch biopsy, or if there is a bleeding diathesis or otherwise. Nowadays, a lot of people do transjugular biopsies. That is, they put the catheter with a little bit of a punch at the end of it, which is like a which has teeth, which will just bite a bit of the liver and pull it out. So they do it through the jugular vein. It goes through the hepatic veins, and then they take a biopsy. This is good during bleeding diathesis because the patient bleeds, he bleeds into his circulation. Surgical punch, of course, during laparoscopy or abdominal surgeries you do. The needle biopsies are, of course, long ones that you regularly see, but in cirrhosis they may be fragmented. The wedge biopsies are, of course, like triangular pieces, but please note a wedge should be very deep, like a cup, and not shallow like a saucer. The reason will come to it. So also note that the needle biopsies are generally done in the right lobe of the liver. So if there is a left lobe disease, you're not going to get it unless you do it specifically ultrasound guided or for some reason we'll see to this. So these are the needle biopsies that you get in the liver. And there are various needles. There are some cutting needles and some aspirating needles. Like the Mengini needle is an aspiration needle. You put in a needle and put some water in a syringe and you pull it out. With the suction, a core of liver tissue is cut. So that is one type. The rest are all the usual cutting type of needles like true cut and so on and so forth. It depends what your gastroenterologist is comfortable with, what your clinician is comfortable with, and you take biopsies in that. All are equally good or equally bad, and they are all safe in good hands, right? Now, what is an adequate biopsy? Especially for chronic and other diseases, what is adequate is a 20 millimeter length or 2 centimeter length, which includes more than 10 portal tracts. And if it is between 10 and 20 millimeters or 1 and 2 centimeters, it generally has between 6 or 10 portal tracts. It is supposed you use the term compromise. It's a compromised liver biopsy. It doesn't mean that you can't make a diagnosis. You can, but it's in some cases may not be that accurate. And of course, inadequate is less than 1 centimeter, less than 6 portal tracts. Now, the reason and which needle should you use? It is recommended we use a 16 gauge needle, which is 1.626 millimeter. 16 gauge is approximately 1.6 millimeter in diameter. That's very important because the core of tissue that you will ultimately get will be between 0.8 millimeter and 1 millimeter. And why this 0.8 is important? Because the distance between two central veins and the distance between two portal tracts is about 0.8 millimeter. So you get a good size lobule, you require at least a width of 0.8. In length it may be there, but in width if it is there, unless it's 0.8 millimeter, you will not get a complete one. So that is why we recommend a 16 gauge needle, and you can take 1 or 2 biopsies or passes, what is called passes, to get at least 2 centimeters length, right? Having said that, people want to be careful or whatever, we are getting biopsies in more and thinner needles. So this is a wedge biopsy. See, it's a good wedge, quite deep. The surface of the liver is covered by thin fibrous capsule, and on top of that you can get few mesothelial cells that you can see on this. Right. Now, when the problem with subcapsular biopsies is that, you know, just below the capsule, for some reason there's inflammation and collapse even in normal individuals. It's not known exactly why this happens, but therefore, if it is a very superficial wedge, you are likely to mistake this as an inflammatory process, which is not true. It's part of the normal thing. So that's why you should know this. Secondly, there are fibrous septa going down for a distance of about 5 millimeters or so below the capsule, which literally anchors on to the underlying liver tissue. The capsule, the Gleason's capsule is quite tough. It anchors on. Therefore, you take a superficial biopsy, wedge, or a needle passes just across the superficial part. It look as if it is cirrhotic, but it's not cirrhotic. You see this? This is part of the normal liver. This is a normal liver. It was a non-cirrhotic liver, but it looks as if you see this will be mistaken for a nodule and so on and so forth. Therefore, superficial biopsies where you see mesothelial cells and all, you have to be very careful. You have to not interpret on that, and be careful to over-interpret inflammation and fibrosis in subcapsular region. So therefore, biopsy should be deeper than 5 millimeters or 6 millimeters or more when evaluating especially portal hypertension. You should not call it cirrhosis when there is no cirrhosis and so on and so forth, right? And of course, it should be technically good like any other section, no folds, no artifacts, and so on. So the other thing that we recommend is, when you're cutting liver biopsies, you have to take serial sections. Try to get as many sections on a slide as possible. Now, if you take, this is the face of the cutting edge of the block, you'll find there's a lot of paraffin on either side. So if you cut a section, you get a lot of unnecessary paraffin. Maybe in one slide you can get 1, 2, 3, 4 sections. But you make it as a wedge so that the paraffin all around is less. You tend to get more sections on a slide because the intervening paraffin, which is of not of use to us while reporting, that becomes less. Our technicians always do that, and they're very clever in this, and that's what it's helpful, right? So please note this. So this is important. So you get multiple sections like this on a slide. That's quite good, you can see many sections, and serial sections are always necessary, as I told you. So now the liver biopsy is interpretation is dependent on technically satisfactory sections. Tissues should be properly fixed, and please work with your clinician always, because there's a lot of clinico-pathological correlation to be done in non-neoplastic diseases of the liver. Unless you talk to your clinician and he talks to you, it will be very difficult to arrive at a diagnosis. Even if you narrow down his 4 differential diagnosis to 2, you have done your job. It helps them, right? So always talk to them. This is true for almost all biopsies and all surgical pathology. You must have a good rapport with your clinicians. In fact, gastroenterologists and we are very good friends. The other thing is you must appreciate that there are certain liver diseases which are diffuse. This is acute hepatitis. See, this area of the liver looks similar to this fragment looks similar to this, and so on and so forth. So therefore, in diffuse liver diseases, it's easier to come to a conclusion even with little smaller biopsies. But in chronic liver disease, this is chronic hepatitis C, you see this inflammation and this inflammation may not be same. Here elsewhere the inflammation may be different. So that is difficult. So you see, for example, in this liver biopsy, the inflammation, the needle is like this, looks a lot more than what is here. And I think that's obvious even to a first year resident. So, but actually, this is a core, this is the same core. So this for in chronic liver disease, that's why that length of liver biopsy that you see is very, very important. It can be patchy. Whenever there is patchy disease, especially in chronic liver disease, you have to be very careful. Unless you have a big core, you're likely to under or overdiagnose. Okay, this is fibrosis. Look, this is the same case on top, where you see the needle goes in 2 different places, and in one the fibrosis looks less. You see in this one it looks less because it's from this area. This one it looks more because it's from this area. So that's another thing. So this is emphasizing you on this. So this is the emphasis on why people ask, clinicians, why do you want big tissue? You want an autopsy or what or not? This is the limitation. The next thing is, having said all that, Can you make a diagnosis in a very small biopsy? Of course. For example, in acute hepatitis, I told you, all lobules are equally affected. You can get one lobule is enough. Sometimes in, say, amyloidosis, this was an amyloidosis, we got a piece of skin and a little bit of liver tissue. And see, there was amyloid, congruent positive. See, this must be less than 1 millimeter size. So, but we made a diagnosis, it's okay. So it depends on what kind of tissue you get and what the diagnosis is. Don't throw away a slide just because the tissue is less. Now, having said that, we'll see let's come to the other things regarding the normal liver. The normal liver has at least 17 different kinds of cells, but we generally tend to see only one or two of them, right? So please note it, almost the majority, 75% of the cells by volume are hepatocytes. Then you have the biliary epithelia and other things. So plus see this slide. All of you see this slide. It's open to all, especially the residents, first year residents. You can see this. You seeing this? This area, if you can identify. What is this area? Can any of the first year residents tell?
Central vein.
Central vein. Okay, good. Then what is this area?
Portal triad.
Portal triad. Very good. You see now, the portal triad is called a triad because it has three structures. This is the vein. The largest and widest structure is the portal vein. Then you have the branch of hepatic artery and a bile duct here. Now the hepatic artery and bile duct embryologically grows together just like two fingers, right? Okay, this is just like two fingers of your close to each other. So they are so tight. So embryologically they grow together. So in the liver, if you see a hepatic artery, a bile duct is invariably adjacent to it. If you find a bile duct, the hepatic artery is invariably adjacent to it. In fact, if you see the diameter of hepatic artery, you take that diameter and draw a circle all around, somewhere there it will hit a bile duct. This is very important in knowing that. Secondly, the hepatic artery and the bile duct have almost similar diameters. They're not very different. So they are of the same diameter, they are similar, but the largest structure there is invariably the portal vein there. And you'll notice there's fibrous tissue in the portal tract, but if you go to the when you saw the central vein, you found there's no connective tissue around. It's just an isolated opening like that. Okay. So this is how they did it. Right. So this is the portal vein. This is the hepatic artery and bile duct. See, the bile duct nuclei are at the base, right? There's cuboidal epithelium. Cuboidal means the breadth and the height of the cube. It's like a cube. In this, we are seeing two-dimensional. Breadth and height will be almost equal. In columnar, the height will be more than the breadth. So these are mainly cuboidal cells. There's a fine brush border if you see here, and there's the artery with endothelial cell. This is an artery here. Here we don't see a bile duct, you have to take more sections, right? So this, what is this area? This is the, anybody, any of the residents, which is this area?
Tract area.
Huh? Yeah, what is it? Sorry, I couldn't hear.
Portal triad area.
Yeah, and this is the terminal hepatic venule or portal. So you have to identify, right? Good. So this is another one, portal tract. This is another portal tract. This is the hepatocytes in between. Very good. So you have been able to identify them. Now you find here, see, this is one portal tract. Portal tract. This is one portal tract. Here it's almost like an open wall. No, there's no wall or separation anywhere here. But you know, in pigs and swines and other animals, there's a nice fibrous tissue all around. So you see, from one portal tract to another, this defines lobules. You know, there's a lobule like here with the central vein in the center and a terminal hepatic venule, what you call the center. And you see here, and here these are the portal tracts all around. But in human beings, it is not like that. In human beings, you have the central vein and then you have portal tracts all around. So people started seeing this and found, oh, it looks almost like a hexagonal area, 6 sides, with a central vein in the center. That must be the approximate lobule in this. So what was started, it's called as initially as Kernighan's lobules. But then Rappaport said that no, the blood flows from the portal tracts to the central vein because of the portal veins and the arteries. Portal veins supply nearly 70% of the blood to the liver, liver lobule or whatever you want to call it, and the artery supplies the remaining 25-30%. So this is the most important area, and blood flows from the portal area to the central area. So we cannot divide like this. This should be actually the central part. Then of course there are portal lobules based on this similar concept. Moll's portal lobule. So it's acinar complex. So this is Kernighan's lobule, and he divided into a centrizonal area around the central vein, mid-zonal area in between, and the periportal area around the portal veins. On the other hand, Rappaport said they are acini. Acini are small part of a lobule in which they are berry-like areas. From the portal tract, you have the first one, then you have the second one, and the third one. The third one has the least oxygenation, and the first one near the portal tract has the most oxygenation. So these are called acini 1, zone 1, zone 2, zone 3. They roughly correspond to centrizonal, mid-zonal, and periportal areas. But the current terminology, when we give reports, we generally tend to write zone 1, zone 2, and zone 3. But you can also use the other older term, right? So this is important. So you can write zone 1, zone 2, zone 3. And because of the acinar count, this one, people have found that this explains the rounded nodules. These are the watershed areas where there's less oxygenation, likely to have more necrosis, and so on and so forth. There are various theories, and this explains what is called the Rappaport's SNS. Okay, so this is how the different terminology is there. So you have periportal, mid-zonal, centrizonal area. You have zone 1, zone 2, and zone 3. So you can use any terminology, but we prefer to use zone 1, 2, and 3. Right? And please note, periportal to centrizonal is about 4 millimeters in size, and from centrizonal, so therefore from between two portal tracts, it's about 8.8 millimeters or 800 microns. So I hope this is clear. All of you are quite clear in this. Okay, so these points are clear. They are roughly but not exactly. Central zonal is zone 3, zone 2 is mid-zonal, and zone 1 is periportal. I hope it's clear now to you all. Okay, this is Aaron Moses Rappaport who described this. Right. Now, is this important, this zonation? It's very important because for example, in biliary disease, the maximum bile secretory and uptake takes place in the periportal area and minimal bile secretory and bile salt uptake in centrizonal area. So when there's excess of bile salts, everything, most of the changes are found in the periportal area. Otherwise also, the um, towards the portal vein, you have more of oxygen, more of gluconeogenesis, beta oxygenation, oxidation and nutrient. And toward the central vein, glycolysis, lipogenesis. Okay, and the central vein endothelium secretes is a part. The endothelium secretes the wind signaling things, and that goes and what it does is it sits on the receptors available on hepatocytes and activates the beta catenin pathway, which moves to the nucleus and tells the nucleus to it activates various processes. So I am telling this in very simple terms. So this is very important. I will come to that later. So and because there is more certain things in the metabolic pathways in the portal venules are different from here. For example, if you want to see for paracetamol poisoning, the enzymes for that are located on the central vein. You have to look around the central vein. You want to see tetracycline effects, you have to look around the portal area. Okay. Similarly, alcohol, look around the central vein. Of course, if it's extensive, it goes all around the lobule. Same for NAFLD and whereas for biliary diseases, of course, and autoimmune liver disease, iron overload, the periportal areas are more important. So this is important. So zone 3 for certain things, zone 1 and for certain things, and zone 2 for certain things. Right? So this is how it is. Please note that. Then you see there is a layer of cells all around the portal tract. This layer of cells is called the limiting plate. This is very important. Inflammatory cells are mainly in the portal tract. Suppose there's more inflammation here and the inflammatory cells spill over and destroy what is called the limiting plate or a single layer of hepatocytes that rims the portal tract. That is forms a boundary between the mesenchyme and the parenchyme in the liver. That is the limiting plate, which are hepatocytes rimming the portal tract. You call it, if they are damaged by inflammatory cells, it is called interface hepatitis. Just like in lichen planus, you have interface dermatitis damaging the basement membrane and the basal layers of the epidermis. Similarly, the cells from the portal tract, if they damage or spill over into the lobule through this limiting plate, it is called interface hepatitis. The earlier term was piecemeal necrosis. So piecemeal necrosis and interface hepatitis is used interchangeably. I hope that is clear. Orderly. Then now we have to see there are certain stains which helps in identifying where the fibrous tissue is, the reticulin stain. The reticulin also gives an idea of the framework of the liver. You see, Masson's trichrome, central vein you don't see anything actually, right? You are only whatever you see fibrous tissue, it's mainly in the portal tract. You can do a serious red. This is the capsule of the liver, by the way. And you see, very beautifully it brings out the portal tract. The central area is hardly anything you find, right? And the other stain, which is very important, is the Orcine elastic state. Elastic tissue is present only and only in the portal tract. If the elastic tissue is present here, then it means there is fibrosis. If there is no elastic tissue there, then it's not fibrosis, right? So now we have seen the various structures in the portal tracts. You have to note that the portal veins can be absent in about 1/3 of the cases. You have to take serial section. Hepatic artery and bile ducts are together absent in about 5% of cases of in some of the portal tract. But you see, on an average, you will find 2 bile ducts, 2 hepatic arteries, and 1 portal tract, 1 portal vein in every tract. Very important. For example, you have to know this, that the hepatic artery containing portal tracts will have bile ducts. If normally, at least if you find 10 portal tracts with arteries, at least 8 of them will have bile ducts. If it is between 5 and 8, that is, if you count 10 portal tracts with arteries, and between 5 and you see 5 or 6 or 7 bile ducts only, in the remaining you don't see, then it is suspicious for loss of bile ducts or what is called paucity of bile ducts. If less than 5 portal tracts have bile ducts out of these 10, then it is called it is suspicious of a it is not suspicious, it means there is definite paucity of bile ducts. So if the ratio is less than 0.5, there is paucity of bile ducts. This is important. For example, in the liver transplant patient who has got chronic rejection, they lose bile ducts. In primary sclerosing cholangitis, they lose bile ducts. In other biliary disease, including primary biliary cirrhosis or obstruction for a long time, the bile ducts are lost. So you have to count the bile ducts, right? So normal portal tracts will have at least, if you count 10, 7 or 8, at least 8 or more will have a bile ducts with the arteries. So this is how this one looks like. So this is the artery. You can't make out sinusoid. We can't make out anything in this liver biopsy. How are they arranged? The liver cells are arranged in the form of a muralium or like a wall. These are the liver cells. They are in packed together like a wall. But the muralium or the wall-like arrangement of the liver, uh, which are seen as cords separated by spaces called sinusoids, they are very irregular, just like a maze. I mean, you enter one place, it's very difficult to say from where you will come out. It's almost zigzag like that. Why? The blood has to flow very slowly. The Kupffer cells have to identify if there are any antibodies coated, it has a macrophage function, and so on and so forth. In fact, the flow in a sinusoid is actually much lesser than the slowest flow in a capillary. If the capillary is between 500 to 1000 micrometers per second in sinusoids, its maximum is around 450 micrometers per second. So the blood flows slowly. See, this is unfortunately the diagrams we teach our undergraduates. Nice central vein. Look, there are fibrous tissue, which it is not there, right? And the cords are arranged straight. It is never like that. It is always like a maze. You see? You want to see parallel cords, look near the central vein. You will find they are a bit parallel. But elsewhere, they are never parallel. As a postgraduate, please note, it is like this. And right, so you see, it's all irregular, it's not straight. And do you get, and in these, the cords of, you'll find the cells are one cell thick, except where it bends and all. There it looks like two cells thick or so on. So this is a single layer of hepatocytes forming a cord. Now, this is what the normal liver looks like. You see, single layer of cords of cells. This is called muralium simplex. This is very important, right? You have to see this is very important. From 15 weeks of gestation to about 5 months uh, of gestation, of post after birth, actually, you may find 2 layers thick of cords. This is normal. This is called muralium duplex. And in fetuses, less than 15 weeks of size, you will find multiple layers of hepatocytes in the cords of cells. That is called muralium multiplex. So anyway, one cord cell thick, two cord cell thick, three or more cord cell thick. In life, in adults, one cord cell thick is normal. By about 5 years of age, they all become one cord. If you find two cords of cell thick, it is seen in regenerating liver, cirrhotic liver, regenerating nodule. If it is three or more, it is HCC. So in HCC, it replicates what you see in the fetus. In regenerating liver, it replicates what you see in the younger age. So you now know the lobule, you know the cords of cells composed of hepatocytes and how thick they should be, and they are irregular, right? You see this. So they are not straight cords. They are 2 cell thick in children, but 1 cell thick in adults. 2 cell are in adults are seen in regeneration. 3 or more means neoplastic HCC. Right? So this is how it is. Once again, please get this clearly. If there are any doubts, please ask me. Near the central vein, you can find more clearly than here. And where it is bending, please be careful. Okay? Look at these areas. Then you see the importance of this is when you do a reticulin stain. In a reticulin stain, it has to always be irregular, right? Supposing it becomes parallel, like in this area, see, that means it is not following the pattern where it is like a maze. It is becoming straight. Even here it is becoming straight. Near the central vein you can ignore, but elsewhere you should not. You see? So this is an indication of loss of normal architecture. People write no loss of architecture and all in cirrhosis. This is the earliest evidence of loss of hepatic architecture. Your architecture should be such that it is like a maze, it's not parallel. Look at this, now it is very clear. You very apparent. You compare this with this area, it's fine. Similarly, in this, you see, this area, if you see, we'll come to that, more of that later, right? So now, residents, anyone, including third years, difference between conventional capillary and sinusoid, open to all. I have been talking only about sinusoid. Anybody has written anything, Ruchi?
So nobody has written anything yet.
Oh God. Anybody would like to tell? Rachita has written slowest flow. Anything else? Fenestrated. Saloni, fenestrated. Very good. Flow velocity. Flow velocity. Anything else? Okay, right. Do you know how capillaries are classified? Capillaries are classified into continuous capillaries, fenestrated capillaries, and sinusoidal capillaries. Right? Okay. And now you see this capillary is continuous. there is a base. These two have got basement membranes without any fenestrations. Okay, the basement membrane in a sinusoid are incomplete. Number one. Number two, the endothelial cells are very tight in continuous capillaries, whereas in fenestrated capillaries, you will have small holes in them, allowing some amount of movement. But basement membrane is here. Whereas in sinusoids, not only is the basement membrane missing in places, there is also large intracellular gaps. So there is free flow of fluid from within the lumen to outside the lumen. Remember, there are three things: continuous capillaries, fenestrated capillaries, and sinusoidal capillaries. We call them in general these are sinusoids, and people mean that these are capillaries. Now, can anybody say where you find these? Continuous, one example; fenestrated, one example; sinusoid, one example. Three organs. Anybody? Any of the residents?
He's written, Dr. Nima has written, fenestrated capillaries are found in the kidney.
Very good. Anything else? Anybody else? Good. Okay, anyway. See,
Sinusoidal capillaries are
okay.
located in the liver.
You see, most vascularized tissue like skeletal muscle, lungs, heart, brain, and skin have got this continuous capillary. Right? Then kidneys, endocrine glands, intestine have got fenestrated. And the sinusoids are present in the reticuloendothelial system, wherever they are. Liver, spleen, bone marrow, lymph node. Very easy. Liver, spleen, bone marrow, lymph node. Fenestrations, kidney, endocrine, and intestine, where some amount of flow is required. Right? For example, these fenestrations in kidneys are so less that it doesn't allow albumins to pass through. Right? So anything smaller than that may pass through, beta 2 microglobulin and so on. So right, but this here nothing passes through unless there is inflammation where there is gap. So then things pass. And the best example would be blood-brain barrier, and so on and so forth. Right. So I hope this is clear now. If anybody asks you anytime, now you understand liver how it is, isn't it? Right. So we go to the sinusoids in the liver. In the sinusoids of the liver, they are very easily there's cross movement. Remember, in the sinusoid there are three cells. You have the reticuloendothelial cells, endothelial cells, and of course you have the fat storing cells of Ito, right? Or they are also called stellate cells. Now, in between this endothelial lining and the hepatocyte, there is a space. That space is called space of Disse. In the space of Disse, you only find only one cell is present, that is fat storing cells of Ito, right? Or stellate cell. Only one cell. The endothelial cells, and lining with the endothelial cells, you will find dendritic cells and Kupffer cells. Kupffer cells are not present in space of Disse. Dendritic cells, which are antigen presenting cells, are not present in space of Disse. I hope that is clear where these cells are located, right? So stellate cells or fat storing cells are found here in the space of Disse. The rest are found there. Okay, that's clear. Very good. View this slide. Open to all, especially the residents. You can find out these two structures. Good. So what is your diagnosis in this? Anyone? What would you write? Anybody? interface. Any of the residents? Don't be shy. Eh? You can always write. There's no make mistakes. Nothing. No harm. Nobody is writing, Ruchi.
Nobody has written anything, sir.
Only one. Eh? Okay. Anyway, these are all fictation artifacts because this is an autopsy specimen. You see everything. All the cells are separated. You see this? The reason why I put this cell with this is to show you that in this unfixed specimen, sometimes you get widening of the space of decay. Right? See, this is the sinusoid. This is all, it has all separated out from the hepatocytes. You see, this is the RBC inside. This is the endothelial cell. This is the space of decay. Right? Just to show you that. You see this? This is the endothelial cell. This is the sinusoid space of decay. This is the space present all around, right? And this might be a Kupffer cell. It might be the endothelial cell. And you're finding this hepatocytes with nucleus and nucleolus, so on. You see this, everything is separated out in the portal tract. This is all fixation artifacts, but this is just to show you. Others very difficult, unless do an EM, you can't find the space of decay that easily. It's all because of fixation artifact. Good, right? We'll go into that. Now we come to the hepatocytes. The hepatocytes are polygonal. They have a lateral surface, apicolateral and apical, sinusoidal or basal surface. So one surface faces the sinusoid. The other surface also almost faces the sinusoid, but in between two hepatocytes, you have a canaliculi because they have cup-like depressions. We'll come to that. So the canaliculi forms by adjacent hepatocytes in between here. See, you don't see them normally. And the hepatocytes are rich in Golgi and mitochondria, right? So, because they're very active cells, they're pink and granular, just like parietal cells, proximal tubules. There's a lot of mitochondria in them. Yeah, and they have a lot of glycogen, which are these dark granules seen in EM and so on and so forth. There's a nucleus with a nucleolus, and chromatin is prominent in most of them. Most of the cytoplasm is slightly rarefied and granular. This is how you identify. Find a membrane which is very thin, and we'll see this. If you do a PA stain, they'll be rich in glycogen, and this is diastase. It's all gone. Another thing you'll find in hepatocytes, once from childhood onwards, is this brownish yellow pigment, mainly in the central area or zone 3 around the central vein, and that pigment is known as lipofuscin or wear and tear pigment or ceroid pigment. That is because oxidation of lipids, as the cell turns over and becomes old, you see it. They are PS positive, AFB positive, and so on. They are granular, like this. Okay. So lipofuscin pigment is common in, that is a common pigment. It's not iron. Please be careful while seeing that. Then see this, between adjacent hepatocytes you have the bile canaliculi with bile. This green thing is the bile. This is just to show you how a canaliculus forms in between hepatocytes. Please, you will never find bile in normal liver. If you find bile, it is abnormal. There is no normal condition in the liver where bile can be seen. It's invisible. Canaliculi cannot be seen. It is absolutely abnormal whenever you see this. Remember this. So that's another thing in the normal which you don't see. Then you saw the liver cells, no? They were looking little large and wonky. As a person becomes older, there is polyploidy in the liver cells. That's why they look somewhat dark, larger with nucleus and all. You sometimes wonder, is this dysplastic or not? That is because the amount of DNA increases to 2 times, or again more, it may be 4n, 2n or 4n as the age increases. See, as the age increases, the polyploidy increases. The number of normal 2n DNA cells will be less. So it becomes 2 into 2n or 4n, or 4 times. You see these cells, they increase as the person ages. This is normal. And why it occurs? See, it's what you see in hepatocytes is there are various theories. One is the hepatocytes may not divide, but the nucleus divide. So it's begin to get some binucleate cells occasional, and these cells with increased DNA because of mitotic slippage or endocycline and so on and so forth. So nothing to worry about that. And it said that polyploidy protects against tumors because there is loss of, but because it impairs heterozygosity, no loss of heterozygosity. So in fact, if you have 4 such chromosomes and there is an autosomal recessive lesion and one of the chromosomes is abnormal, still nothing will happen. Like in this case, you see, here one is abnormal, we are finished. Here one is abnormal, nothing happens because there are 3 more to protect you and so on and so forth. So it protects against tumors. These are the theories, and therefore it provides support to tumor suppressor gene copy. So this is normal. Please remember this. Okay, you have to remember this. The maximum polyploid is seen in zone 3 or centrizonal area, and the least is seen in the periportal area. So don't get worried about all this. As you just ask the person's age. If you do a Ki-67, it will not be raised. In livers, normally it is less than 1%. So no problem at all in this. What is this? Anybody can tell? Anyone? You have to take just few seconds.
That is a apoptotic body.
Okay. You see, apoptotic body, it looks as if somebody has put in a syringe and pulled out all the fluid into it, right? And later the DNA becomes hypnotic, you don't see it. Here it is within the nucleus. No, this is the nuclear membrane within the nucleus. And you see, this is an intranuclear inclusion. This is CMV. Okay, so please be careful of these things, right? You see this, and you're finding polymorph, polymorph, polymorph here. In CMV, you generally find polymorphs, right? You see this. Generally, if more than 50 or 75% of the area, if it occupies, you can be rest assured it's an intranuclear viral inclusion, mainly CMV, right? Okay, don't mistake it. Please note the hepatocyte always is a labile cell. Yeah? It's a stable cell. It does not proliferate as much as an endometrium or the gonadal epithelium. So, but it can proliferate just like in the kidney and other things. And the average lifespan is about 1 to 1.3 years. And because it turns over, although you may be 20-year-old, actually your liver is about 3 years old. All the cells keep on renewing. You have a lot of wear and tear and so on and so forth. And that's very important so that metabolically, you're absolutely fine always throughout your life. So their average age is less than 3 years. And apoptotic cells you hardly find. If you count 10,000 cells, you'll find only 1 to 5 cells. So this is the liver biopsy. You will see how much of fat do you see? Normally less than 5%. Why do you know it is less than 5%? Because They have done a lot of autopsy studies and in cadavers, healthy subjects, and so on and so forth, ultrasound, CT, so on and so forth. And it's all, everybody says it's less than 5% they're found in people who have no disease. So therefore, we know that any fat more than 5% is abnormal. So with this, please see this slide. Liver biopsy. Liver biopsy. There are some cells here. Note these cells. Anything else you find in the liver, just see. What would you like to know next? Anything in this? Somebody said, what is it? Inflammatory cells are about to levels of bilirubin, hemoglobin, age of patient, nothing else. Anybody?
They're saying age of the patient, C.
Why? Anybody can say why?
Because some AB has written presence of NRBCs are noted.
So we'll give some time, 20 seconds to the rest. Lot of people have written extramedullary, neonatal letter, Manisha. Okay, so that's all, no?
Yeah.
Very good. I think all of you have diagnosed it correctly. This is neonatal liver, extramedullary hemoptysis. Very good, Ruparchana. So all of you, see, first you note, you see, the liver cords are 2 cell thick. So therefore, it must be below 5 months, or you will not see so much of double cord cell thick. Okay. Then you're finding lot of NRBCs, plus this must be a megakaryocyte there. Right, and they are, you see, because they look almost like pycnotic nucleus with this red cytoplasm all around, eosinophilic cytoplasm. And this nucleus looks almost pycnotic compared with this hepatocytes, and they are found in clusters. Very good. Right? You are finding this. This is an adult liver. And you see there's not so much of polyploidy. Look at this megakaryocyte. This is within the liver. They are all outside the liver. They are mainly in the sinusoid. You're absolutely right to all of them. You said this. And once again, don't mistake them. So this is neonatal liver. So it means there's extramedullary hemoptysis. Till what age will you find extramedullary hemoptysis in the liver? 5 weeks, 6 months, 1 year, 2 years. A. Namrata. Mohole. A. In Prakhar B. Wow, so maximum people have said A. Yeah, absolutely. It is 5 weeks. It's around 5 weeks you get extramedullary hemoptysis. Right? And it stops. The liver is the last organ where the hemoptysis occurs, and around 5 weeks, from 5 weeks it decreases. Very good. So in pediatric patients, EMH you can get up to 5 weeks. You can get some iron during this period because there is all these RBCs, sometimes these normoblasts can also break and you can get some hemocytin, but they are very little. Okay, so it's normal up to 5 weeks. Very good. Is there any tumors where EMH may be seen? Just give some names. Just one or two, just for fun. Anyone? Hemangioblastoma, very good. Hepatoblastoma, carcinosarcoma, okay, anyway, there's a long list. Okay, so usually the childhood tumors like hemangioblastomas, hemangiomas, hepatoleomyomas, has been described in lot of tumors that you get this. Good, good, good. Right. The next is how will you differentiate between this is benign or it's part of CML. But this was a baby. See, the main thing is you will find a predominant of erythroid cells when it is a benign proliferation. Neoplastic, generally it's a part of a myelodysplastic syndrome, so you get lot of megakaryocytes and myeloid cells, right? And the megakaryocytes are dysplastic. If you find lot of normal megakaryocytes, then it's very likely to be benign. The second thing is this tyrosine kinase things, no receptors you have to do. If you find CD117 or sometimes you can do CD34 or TDT, then it is always neoplastic. You don't find it in benign tumor. Then of course you can do this molecular and specific things. Remember, if you see lot of erythroid cells and normal looking megakaryocytes, think of a benign process. If there are a lot of these myeloid series, dysplastic megakaryocytes, less of erythroid cells, CD117 positive, think of a neoplastic process. So if you have a doubt, no, whether this liver is normal or abnormal, you can do that. Now we have finished the other parts. We'll just go to the bile ducts. So you see, these are the bile ducts. You have the large bile ducts, mainly outside the liver, small bile ducts, and this hepatocellular canaliculi. So this is how it is in the liver. Two adjacent cells, they cup together and they form canaliculi. Right? The canaliculi are formed by the hepatocytes themselves. There are no separate cells there. Right? So there's almost like two grooves joining together to form canaliculi. Now there are specific nomenclature for this. You have the bile canaliculi and canals of herring. So this is up to the portal tract level. Then in the portal tracts, you will get ductule. So from canaliculus and canal of herring, the next term that you use is ductule. So you will get bile ductule, and then it becomes little larger. You use the interlobar bile duct. So the term duct is used first in the interlobar bile duct. So you can call it bile ductule and then interlobar bile duct. The rest are all ducts. Then you have area bile duct, segmental bile duct, then of course right septal, and then you have the right hepatic and common hepatic ducts. Now the moment you come to the stage of septal bile ducts, then you start seeing glands around these ducts. So interlobar bile duct will not have, but the next stage, septal bile ducts will have these periductal glands. So this is one way of identifying the larger ducts. So terminal bile ductules, canals of Herring, they are less than 15 micron. 15 micron is about the size of a neutrophil or a large lymphocyte. Less than that you will get. So canaliculi and all. Normally canaliculi you don't see. Canals of Herring also hardly ever see in the normal liver. Small bile duct, then you go to the portal tracts. Interlobar bile ducts up to septal ducts are 15 to 300. Then 300 to 800 are the large bile ducts. They are starting from the area bile duct and segmental and then right and left hepatic and common. Okay, there are about almost 8 to 10 generation. So this is the terminology you use, right? So you see, so in the hepatocytes, then you have canals of Herring near the portal tracts. Then it forms the bile ductules, right? So from canaliculi, canals, then you have the ductules lined by large and small cholangiocytes. Canaliculi are only hepatocytes. Canals of Herring. These cells lining canals of Herring and all, they can regenerate to form hepatocytes. So this is how it is. Canaliculi, and then you have this. So you see, this is how there is a hierarchical system. Canals of Herring, ductules, interlobar ducts, and septal ducts, area ducts, segmental and large ducts. 15 to 100 is interlobar ducts. And septal ducts are larger. You start seeing periglandular, ductal glands here, right? Their pH positive. This is a canal of Herring, right? And this is the going to form the interlobar duct. These are interlobar ducts, right? So this is the terminology you use. Look at this. Once again, you don't find bile canaliculi and bile in normal liver, right? So this is how it is. Sinusoid we have seen. Now Kupffer cells can we stain? We don't stain them normally. Sometimes when there is hepatitis, they gobble up all the seroid pigment and you do diastase pass, they become positive. So whenever there's liver cell necrosis, it's an indirect way of telling they are. The stellate cells cannot be seen. They are fat storing cells. But if there is hypervitaminosis A, you'll find this little fat like things very near the sinusoid. So that's an indirect way of finding out this fat storing cells. They are very rare. You don't see them now. So now that finishes the normal liver. Do you do any immunohistochemistry? I'll quickly run through immunohistochemistry. Please remember these numbers 7, 8, 18, 19. 7 and 8, and here 18, 19. These flanking ones are 7 and 19. Both are prime numbers, they are odd numbers. 8 and 18 are even numbers and they are inside 7, 19, 8, 18. These are four very important immunohistochemistry we do in the liver. So what is important of why the 7 and 8, 8 and 19? What we do is, right? So we see all the four can stain bile ducts, but 7 and 19 will not stain hepatocytes. So therefore, if you want to see any biliary disease well, you have to do 7 and 19. 8 and 18, you can stain for hepatocytes, but you may see some bile ducts also, right? So 8 and 18 even numbers are for hepatocyte. 7 and 19 are for bile ducts. So 7 and 19 are the ones. If the bile ducts is lost, you can't see, then you do this staining. Okay, I hope that is clear. That's one immunohistochemistry. Then the other immunohistochemistry is that there are certain urea cycle ones. One is arginase that helps in the formation of urea, which is excreted by the kidneys. That is one thing. Then you have glutamine synthase, which is used for converting glutamate into glutamine, and the glutamine is required once again in all this structure. So, and there is glycopan 3. It is a proteoglycan which is attached to the cell membrane, and it's involved in cell growth, signaling. It supports tumor proliferation, invasion, angiogenesis, and helps in these liver cells. Whenever there's hypoxia, it helps to adapt to hypoxia by stabilizing c-Myc protein. It promotes glycolysis and so on and so forth. Therefore, because it helps in cell growth and signaling, in adults you will not find except in neoplastic conditions. This glutamine synthase is found in the, you see this? Which area is this? It is found in the perivenular area of the liver. Glycopan 3 absent in adults. Arginase is present in hepatocytes. So if you want to find a tumor, whether it is hepatocytic in origin, you can do arginase 3. You want to find whether it's malignant or not, you can do glycopan 3. In fetuses, of course, glycopan 3 will be positive, right? And glutamine synthase has this very nice appearance, perivenular in normal. So if it's some abnormal pattern, you know there's some abnormality. Hepar3 is an antigen which stains hepatocytes in paraffin sections. So that is also used to identify liver tumor, right? Okay, you see this is the map like pattern of glutamine synthase in focal nodular hyperplasia of the liver. There also, you know, you get map like because there are abnormal vessels. Very good. This is diffuse in hepatocellular carcinoma, right? So remember these are the other enzymes that are used. These are urea cycle. Then you, for bile canaliculi, you can do polyclonal CA, not monoclonal. The if you see capillaries and all, you do CD34, they will stain. But in the liver, the normal endothelial marker CD34 does not work. So in the normal liver, CD34 is absent. In hepatocellular carcinoma, they are present. So CD34 is absent. Now bile canaliculi, other things that you can do is bile salt excretory protein. It will stain the canaliculi, or you can do a multi-drug um, resistant MD3 and so on so forth. So they will help in identifying canaliculi. In certain diseases, they are absent. Okay, we'll come to that later. Alpha fetoprotein, normally it doesn't stain the liver except in fetuses. So in fetuses, you can get glycopan 3, you can get alpha fetoprotein. So for the endothelial cells, you can use CD4 or ICAM1 or CD31 low levels. You can use or STAB2. So this for endothelial cells, CD4 is a good stain. This stains the Kupffer cells, CD68, and these are other stains. Most of the cells in the portal tracts are CD8 positive. So this completes the normal liver. So you are fully equipped now. You know what are the changes that you get normally in aging and so on, so forth. So I hope you are now settled. Any questions regarding normal liver? Let's clarify it right now. You know about extramedullary hematopoiesis, how long they are present. They are present in other, then you have to get worried. For example, in this one, no, aplastic anemia. There's a stem cell defect. When there is a stem cell defect, so you won't get extramedullary hematopoiesis even if the bone marrow doesn't produce. So you don't get a spleen which is palpable. You don't get a liver that is palpable. You do a liver biopsy, you will not find any extramedullary hematopoiesis. So these are clinico-pathological correlations we will do. So now we have come to normal liver. Your liver biopsy slide has come. What are the stains you will do? The most important is HND. We also do diastase pass, reticulin, and mesenteric. We'll come to that. This helps in identifying Kupffer cells. I told you, if there's indirectly, if they stain, you know, there's liver cells of necrose or alpha 1 antitrypsin bodies. Reticulin will tell the architecture and mesenteric for fibro. These are not special stains as far as liver is concerned. We call them usual stains. This is what I learned in UK when I learned this. They called it usual. Special stain orsin, pearl-stain, rhodanine, microorganism, and immunohistochemistry. We don't do much immunohistochemistry for non-neoplastic diseases, right? So you see, why do we do diastase pass? This is PAS. And see, it stains everything. You don't know what it is. You can't make out what it is. What is there? It's all full of glycogen. Please note, in some livers, the glycogen stains only one pole. It is known as creaming effect of glycogen, and that's a fixation article. Anyway, so glycogen stain. Now, see diastase pass, same case, you are able to find out alpha 1 antitrypsin bodies because they are not because of glycogen, no? Right? These alpha 1 antitrypsin bodies, it gets secreted, but it's not excreted out. There's a secretion excretion block. So this is alpha 1 antitrypsin bodies, and these are the macrophages with diastase pass positive spheroid or lipofuscin pigment, indicating there must have been a recent hepatitis or necrosis. It helps. Now you see reticulin. This looks like a cirrhosis, but not complete. It's not seen here. This also might be cirrhosis. You're not sure whether it fragmented or not. And this one is a case of portal hypertension. Does it look normal or abnormal, this one? What do you think this is? Let's go to this. What are the votes for this? Anyone? Any resident, please, third year resident? Prakhar, you want to say something? Nobody is writing, Ruchi?
Not yet, sir. No one.
No one. And the second one? Case of portal hypertension.
No answers.
Oh God. Okay.
Okay, AB has written second one is nodular regenerative hyperplasia.
Very good. Excellent. Okay. You see this first one? It may be cirrhosis, but you see this? It shows a thin reticulin fiber all around. This is a nodule. So you are more confident in making a diagnosis of cirrhosis. It helps. And this one, as AB has written, you see this nodule here? It is not very apparent in HND section, although it looks here, you can imagine it might be, but you are not sure. But if you do a reticulin stain, it's a nodular regenerative hyperplasia. That explains the portal hypertension, right? So you see, reticulin helps in these conditions. That's why we do. And this is reticulin. Why is reticulin absent in this? And absent here? Anybody? Okay, I'll go to it. See, reticulin is absent in hepatocellular carcinoma. It's a poor man's way of suspecting hepatocellular carcinoma right away when you do an HND and reticulin. Even in an adenomatous nodule or dysplastic nodule, you get focal loss of reticulin. But in fibrolamellar HCC, where there's fibrosis, you'll obviously get reticulin. So you see, reticulin has so much uses. You have to do it properly. Unfortunately, nobody looks at it. And I told you about the laws of architecture earlier, right? Mason's trichrome, of course, it tells you beautifully about the collagen. You can do serious red. And you see, the elastic tissue, whenever there's fibrosis outside the portal tract, it will get stained. Beautifully, it stains. Yes. Of course, it has other advantages to do. You can find out, you see, these are hepatitis B surface antigen positive cells or Shikata cells in an Orsin stain. Orsin stain also helps in identifying copper binding protein. Whenever there's biliary disease, Wilson's disease, because if there's biliary obstruction, primary sclerosing cholangitis, the copper doesn't get excreted. So you get increased copper and copper associated protein. It stains copper associated or copper binding protein. It doesn't stain copper. Copper is stained by rhodanine. So this in biliary obstruction you will get. In Wilson's disease, of course, that's a separate disease. There also you get increase in this copper associated protein. So these are the stains that you do normally. And please note, you see, in patchy disease, this is a liver biopsy 3 cores. The 3 cores, this area showed fibrosis and cirrhosis. This area and this area showed hepatocellular carcinoma. So if your clinician thinks this is blood and sends 3 pieces to 3 different labs, you are likely to get 3 different diagnoses in such patchy disease. Please tell your clinician that you will not see such biopsies if they are divided and sent elsewhere. You send it to one lab, let them process, let them do it. You send me the slides or the blog. You have to see a case in total. This is very important for you to know. Other thing, anything wrong in these portal tracts or anything? Are these portal tracts normal? Anyone? Any resident? No vein?
Prakhar says no vein.
This one, yeah. In this is the vein. Anything? Ductular
Manisha
proliferation.
says ductular proliferation is noted.
Okay.
No venule.
Mandeep Singh. In this. And in this is a separate case, A and B. B also same.
AB says duct edema is seen,
In
and
B.
Dr. Manisha says there is increased fibrosis around it.
Well, I would agree. See, in A, this is a portal tract. This is a hepatic artery. Yeah, okay. This is a bile duct next to it. Wonderful. Hepatic artery, this is a bile duct here. A little bit. Fine. But what you do not see is the portal vein. Right? So you see here you are not seeing a portal vein. This is a Mason's trichrome. This is a portal vein. This is an artery. What you don't see is a bile duct. So there is a loss of bile duct in this. There is a loss of portal vein in this. Now you have to interpret it. Well, one portal tract out of 10 not showing portal vein doesn't matter, or one not showing a bile duct doesn't matter. Now supposing somebody says, this is the case of portal hypertension, spleen is large, there are esophageal varices, then this might be a non-cirrhotic portal fibrosis, NCPF. Supposing someone says, oh, this case has got actually loss of, a lot of cholestasis, this and that. So this might be a part of a disease where there is vanishing bile ducts. PSC, whatever it is. You have to see the other parts of the liver and so on. So therefore, the bottom line is you must examine systematically with utmost care. All PGs, if you get a pure red cell aplasia in the bone marrow in your exams, you're likely to miss it unless in your mind you mentally say, where are the erythroid series, where are the myeloid series, where are the megakaryocytes. You'll just see some myeloid and megakaryocytes, forget about the normoblast, and you'll miss the pure red cell aplasia. Same thing happens here. So examine very carefully each portal tract, take your time. So that is on bottom line. Now see this. What is your diagnosis in this? Anyone? Just for fun, let's see.
Neutrophils are seen in the sinusoids.
Very good. Somebody said neutrophils. Very good. Anything? CMV.
CMV.
Okay. Spotty necrosis. Okay. Microscopic steatosis. Okay. Well, there is neutrophilic infiltration, and they are here in. Here it's not in the sinusoids, in the hepatocytes. Therefore, all those who said spotty necrosis, we would agree. But they are all neutrophils. And so when you see neutrophils with this little bit of necrosis here, this and that, so then then it may be seen in surgical hepatitis. Suppose they are doing surgery, some shunt surgery, removing the pancreas, doing a Whipple's, and then take a liver biopsy, you may get neutrophils like this. It has no deleterious effect, nothing. So you have to know the history. Have you done a surgery? You can get it in alcoholic hepatitis. There could be Mallory's hyalin somewhere lingering, or you could get in cytomegalovirus infection, as rightly pointed out by one of them. So one of these three things you have to think. Now, how will you identify all this? You need a good history. You need a good clinico-pathological correlation. At least you should, a lot of differential should come in your mind, and you do. So therefore, you must know that in non-neoplastic diseases, the histological responses are similar. Whatever the variety of diseases will have same thing. In liver biopsies, you will just see necrosis in most of the hepatitis. Necrosis, you will find inflammation, you will find cholestasis, you will find ballooning, and you will find fibrosis. These five things you will always find in most of them. It's a combination of this. So a lot of clinical pathological correlation is this. So therefore, once again I am telling you, you must get adequate history and laboratory data, essential for interpretation. And you must remember, when you're doing a liver biopsy, you're sampling 1/50,000th of the liver only, not the entire liver. So therefore, you need a lot of this to be done. With this, I end all the normals and basics for your identification of a liver biopsy. With this background in mind, we'll see the cases, as many as possible, one or two today, and the rest will do it because it's taking time. Okay. Now, any doubts, anything till now you have? Because now the team of residents will take over. Yes? Anybody has any doubts? Anything you want me to clarify till what I've said now? Normal and certain important things required for diagnosis. The background. Anything, Rashmi and this?
Sir, no
Nothing?
questions. No, sir.
No, Amrita, nothing?
No, sir.
Okay.
Nothing, sir.
So I will go on. Case 1. This is what was circulated to the residents. 17-year-old male with abdominal pain, jaundice, tender hepatomegaly, 4 weeks duration. high transaminases, phosphate raised, and viral markers were negative. Okay? All of you are fine with this? Those 8 residents, group 1, you have seen them. It's okay? Anything you want to know? Clinically
question.
acute hepatitis. Okay, Dr. Mandeep Singh is right. Anything else? So they did a liver biopsy in this. All acute hepatitis. Good. So these are the liver biopsies that was given to you. 2 cores are here. This is in a little higher power. This is the reticulin stain. This is the mesons trichrome. Higher power. So would you like to perform any other special stain, and what is your diagnosis? Whatever background I've told till now. Manisha has written acute hepatitis. Good. Autoimmune acute hepatitis. Good. Bridging necrosis. AV. Good. Good hepatitis. Okay, good. You know, all those who wrote acute hepatitis, it's fine. That's okay. But
Serology for hepatitis A and E.
Suman has written submassive necrosis. Okay, good. Right. Let's go back to these slides. You're finding, so you describe there are 2 cores of liver tissue, right? And in these 2 cores, what you're finding is these areas where there are hepatocytes and these areas where there are no hepatocytes. Looks like some bile ducts maybe here in this part, maybe bile ducts here. Such wide ones nearby, maybe portal tracts, we don't know. Okay, you're finding hepatocyte. Looks like ducts here, but anyway, that's gone the high power. Higher power, you're finding this bile ducts here. Yeah, here there are. And there's something inside, so that must be bile inside, cholestasis here, right? And this area, there are no hepatocytes. We don't know whether it's fibrosis or what it is. And there are hepatocytes here, okay. Same somewhere here also, you're finding these. Right, these are under higher power. They're actually not ballooned, you know. Right, balloon means they should be watery and clear. There are some of these could be fat-like thing. And here there's the inflammatory cells. Yeah. And here same thing. And here maybe bile here.
Bile plugging.
Bile plugging. Very good. You're finding actually these are holes, but you're finding this something dot-like thing which is greenish or brownish. This is actually intrahepatic cholestasis. Small cholestasis there. And then somebody was asking about apoptosis. See, this is an apoptotic body. Finding this. This looks like somebody has put a syringe and pulled out everything what was there, and the small nucleus. In this, the nucleus is gone. And here, what you are finding is, you are finding remnants of some blood vessels like this. See, these are RBCs, RBCs, RBCs. So when you see these, you think there must be, these must have been hepatocytes here, which have become necrotic, and these are the remaining sinusoids. Look here, right? Yeah, this might be that. Same thing here. See this? Blood vessels here. This unlikely to be fibrosis, but anyway, one has to be careful. Fibrosis here and this. And you're finding this, there's a portal tract here, there's a portal tract here, and in between everything has gone, you know. Here the same thing. And the reticulin it looks like as if there's fibrosis here. But what happens is when the reticulin collapses also there might be a similar appearance. So you are not sure whether it's fibrosis or whether it's collapse, because we thought that cells became necrose, the sinusoidal some RBCs are remaining, so they have come close to each other. So that is a collapsed area and so on and so forth. But that gives a room for doubt. Do you think it is fibrosis? It looks almost like fibrosis, but we are not sure. Mason's trichrome, well, this is dark blue. Here it is not dark blue. Light blue color is there. We are not sure. So this aniline blue is the counter stain, for this one. So it looks as if, histologically at least, it looks like acute hepatitis, and there is bridging necrosis in the sense from one vascular area to another vascular area, right? And here's the portal tract. So it's almost portal, central portal, and so on and so forth. You see, this one to here. The same thing here, you're not sure. So I would like to do any other special stain in this case. I told you about one stain which is found only in the portal tract. When there is fibrosis, it will be seen. Copper. No, what stain? Any stain? Reticulin. Reticulin we have done, Namrata. I showed you the reticulin, no? We are not sure. Any other stain? Pass, serious red. Okay. Pass with acid, serious red.
Or C. Dr. Ansu has
Orsin.
written
CK 719. Why Orsin? Who has written Orsin?
Dr. Ansu.
Okay, Anshu. Oh, yes, okay. Yeah, you're right. You have to do Orsin stain. See, Orsin here, it is present in the portal tracts, but not in this area. If it was fibrosis, it should have been seen here. Not there. So therefore, that is what we thought of bridging necrosis. It is bridging necrosis. So this is a case. See, it should have been like this if it was fibrosis. It's not there. So the diagnosis is acute hepatitis with bridging necrosis. Right? You see, this is what bridging necrosis is, and this is ballooning. Ballooning means cells should be enlarged at least 1 to 1.5 times, and they're full, they're rarefied, and they're almost empty. That is because when the cells are damaged, the sodium potassium pump doesn't work. Whatever fluid is there, it's almost like an intracellular edema, it's full of fluid. It's what was called a hydropic degeneration. In general pathology, you must have learned. So the sodium potassium pump. So that is what is ballooning. In liver cells, they become enlarged at least 1.5 times, right? And there is cholestasis, and there is necrosis from one vascular area to another vascular area. So that is bridging. It looks almost like cirrhosis. So that comes to us to the question of what are the types of necrosis. If one or two cells are necrosed, it's called spotty necrosis. If more than a group of cells, nobody knows the number, then you call it confluent necrosis, right? Now, confluent necrosis can be just unqualified, or it can be qualified when it is from one vascular tree to another. It is called bridging necrosis. If the entire lobule is gone, it's called panlobular or panacinar necrosis. So whenever there is panacinar necrosis, the liver span will decrease. The clinicians do a percussion at the side and see the liver span, or do an ultrasound, the liver will be shrunken. Most of these patients will go in for hepatic encephalopathy. Then another type of necrosis is when the limiting plate is destroyed, that is called interface or piecemeal necrosis. Very good. So you have spotty necrosis, single cell, group of cells, confluent necrosis. If you want to qualify extensive, it will be a bridging necrosis between portal to portal, portal to central, or central to portal. Of this, which is worse? Worse is portal to central. It can be central to central or portal to portal. Portal to central is worse because the portal blood gets shunted to the systemic circulation, and of course all the things that have to be removed by the liver doesn't get removed. And panlobular, of course, the entire liver goes. So these are the types of necrosis: spotty, confluent, interface or piecemeal, bridging necrosis, and panlobular panacinar necrosis. Any doubts? Anything you want to ask now? Clear? Clear?
Sir, I have one doubt.
Yes, yes, yes. Please tell me.
So why did we perform the Orsain stain in this case?
See, the doubt is, please ask him. Doubt is, you see in the reticulin, is this fibrosis or not? Might be, no?
Yes, sir.
It looks like, but actually it's collapsed. The sinusoids which are separated have come together. But you want to confirm this. In Massons, you see, here it doesn't stay in that much, right? But you see,
Yes, sir.
somebody may say, no, 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 I'm seeing little bluish here, there, and all. You want to, but in Orsin, you see, it's quite clear, no? There's no staining here. So therefore, if there was fibrosis, it should have been like this. There is no fibrosis, so that's how it helps. I hope it's clear now.
Yes, sir.
So Orsin is a good stain for that. Now, bridging necrosis is a bad prognosis. And somebody said submassive. Could you please repeat concept of necrosis? Which one? Dr. Hena, what do you want to know? The different types of necrosis?
Could you repeat the concept of?
Yeah. What? Different types of necrosis. Dr. Hena, do you want to know that? Yes, okay. Now, suppose one hepatocyte is necrosed or two hepatocytes are necrosed. It is called spotty necrosis. Now, in the liver, most of the diseases, common disease for which biopsy is done, is acute or chronic hepatitis. Acute and chronic hepatitis are mainly viral diseases, right? Now, the reaction to virus is not neutrophil. The reaction to virus is lymphocyte. So therefore, right from beginning, when people found instead of a hepatocyte, they're finding one or two neutrophils, right? So that is presumed that the hepatocyte has undergone necrosis and it's been caused because of lymphocyte. Now we know because of virus, no? the T lymphocytes come in or NK cells come in and destroy them. So if one or two hepatocyte is necrosed, then it is called spotty necrosis. It may be in one area, it may be in multiple areas. So that is spotty necrosis. So the indirect way is finding lymphocytes and this. In the case of alcoholic CMV, you will find neutrophils instead of some hepatocytes. Hepatocyte not there, a group of neutrophils, as we saw in that case of surgical hepatitis. Okay, so that is spotty necrosis. When there are a group of hepatocytes, 4, 5, 6 or more, it is called confluent necrosis. Confluent means more. When they are as if the spotty necrosis have become confluent or joined together. So that lot of hepatocytes confluent, one or two hepatocytes spotty. Now this confluent necrosis, suppose it is between one vascular tree, portal to portal or portal to central or central to central. It's like a bridge between these two vascular areas, then you call it bridging necrosis. Supposing the entire lobule has gone. Here you see there are surviving hepatocytes as well as necrosis from one area to another. Here there are no surviving hepatocytes throughout the lobule compared to this. You see this? The entire lobule is necrosed. Here it is only from here to here, here to here. The remaining hepatocytes are surviving. This is called panlobular or pan-acinar necrosis. Then the limiting plate, the one layer of hepatocytes I told you, surrounds the portal tract. If the lymphocytes from the portal area go and nibble into this and enter the enter the lobule, it is called interface hepatitis or piecemeal necrosis. I hope that is clear now. You see here, you're not finding the limiting plate cell, but you're finding these lymphocytes going in. We'll come to that more in detail when we see some more cases. Got it? Thank you. Good. We'll proceed. You see, this is what necrosis is this? Anybody? This area? Any other?
Confluent necrosis.
What type? These are surviving hepatocytes. This will be
Bridging necrosis.
very good. This is bridging necrosis, but this area, all the hepatocytes have gone. So it is
Panlobular necrosis.
very good. Good. Excellent. So this is panlobular, and there it is pan-acinar. So there is a combination. There is you can write in your report extensive confluent necrosis with areas showing both bridging necrosis as well as panlobular or pan-acinar. So that is, it will convey to the clinician, oh, there's a lot of problems going on here. Okay, see this surviving hepatocyte, you could call this bridging, not panlobular. Do you do a reticulin stain in this? Look, you see it's a nodular regenerative hyperplasia like or fibrosis. Mesons also you're not sure, but do an ORC, it will not be there. Cirrhosis, it will be there. Okay, so that's clear. Now see the hepatitis, somebody told it's acute and all, very good. I see hepatitis, clinically it's classified into acute and chronic. 6 months is the cutoff point. Why 6 months? Because in 1968, I think, there was a paper in Lancet where all the pathologists in UK usually and US and all, they joined together. They're called gnomes. They joined together and they analyzed a lot of liver biopsies. At that time, people used to do liver biopsies for hepatitis because they never knew about hepatitis C, hepatitis E, nobody knew. B was known, some of A was known, and so on and so forth, but nobody knew. They used to do liver biopsies and they found the changes of acute hepatitis disappear in 6 months' time. So 6 months is used as the cutoff, but now we know that clinically sometimes patients present with only 3 months history for chronic hepatitis. But anyway, that is how it is. So acute hepatitis can result in acute hepatic failure. That is, acute hepatic failure is when you get hepatic encephalopathy within 4 weeks from the onset of disease, right? Or if the hepatic encephalopathy occurs after 4 weeks but before 6 months, it is called subacute hepatic failure. Now this acute hepatic failure and subacute hepatic failure are bad because this. But conventional acute hepatitis, many of us would have got hepatitis A or E without even most of us would have got without even knowing, like flu, right? Conventional hepatitis, they don't get any of this encephalopathy and other things. They get jaundice, they become all right, and they recover. But acute hepatic failure, encephalopathy within 4 weeks. Most of these patients will have extensive confluent necrosis, usually pan-lobular or pan-acinar, and some bridging, like I showed you, sometimes mixed. Subacute hepatic failure is common in our country and in Southeast Asia. So what happens is, patient is going on downhill. After some time, he gets some encephalopathy. A spleen which was not palpable becomes palpable. He develops pedal edema, a little bit of ascites, and it doesn't become all right. So, it looks almost like cirrhosis. And people did biopsies, and it was actually described in India. We all were involved in that, and a lot of people earlier were involved in that. And it was found most of them, 80% of them, will have bridging necrosis. In subacute, you get majority of people having bridging necrosis. And that time, it was very important to do stains like Orsin, because everybody told spleen is palpable, pedal edema, some ascites, encephalopathy, this is all cirrhosis. It's not bridging necrosis. So stains like Orsin help. So that is subacute hepatic failure. The most of them, they have bad prognosis. Both of these, fortunately nowadays, you can do a transplant. Chronic hepatitis more than 6 months. Problem is most of them go into cirrhosis or hepatocellular carcinoma unless treated either through cirrhosis or directly, and of course they have bad prognosis. So this is how clinically it is. You have to understand this little bit of classification while seeing liver biopsies. Okay, acute, chronic. Conventional acute hepatitis, recovery. Acute hepatic failure, encephalopathy within 4 weeks. Subacute, 4 weeks to 6 months, encephalopathy, liver failure. Okay. Then acute hepatic failure, the other signs, and other than encephalopathy, you have jaundice, then INR becomes abnormal, right? They undergo bleeding and so on and so forth, because coagulation factors are all produced in the liver. And then, of course, they go into this problem. Chronic hepatitis, unless treated, they go into cirrhosis. Then they may either die of decompensation or go into hepatocellular carcinoma. Chronic hepatitis sometimes directly. So this is the thing to remember. So what do you see changes? Acute hepatitis, generally you'll find ballooning change. The liver cells enlarge 1.5 times the normal size. Sodium pump is not working, full of water, hydropic change. Now the cells do not work, so the bile is not excreted. The balloon cells press on the canaliculi, there is cholestasis. Also that is added to it. So everything combined, you get also a lot of cholestasis, which you can see. Canalicular cholestasis. Bile within the cells is called cellular cholestasis. Then, of course, you get necrosis. The T lymphocytes will come, if they are viral, and you get apoptosis. You see this? And apoptosis is good in a way because it allows the cells to come out of the reticulin framework and destroy it. the framework remains as intact as is possible. Single cells, it's not like this. Or of course, if it is very severe, then you get confluent necrosis, which can be bridging or panlobular, right? And then if you see the liver after a few days, you'll find the scuffer cells are all staining slightly brownish in color. You wonder whether it's bile or not, and as days pass, we'll highlight this, indicating that the cells were necrosed, the ceroid pigment that was there is engulfed by them. The Kupffer cells gradually move towards the portal tract, and ultimately in the portal tract you will find macrophages with diastase pass material present. You can get fatty change and all. For example, hepatitis D, you get fatty change and so on and so forth. This is what you get in acute, okay? Right? So this change can be seen in drug-induced, autoimmune, other viruses. You cannot make a distinction very easily in this. There are some subtle changes, of course. For example, in drug-induced, usually or toxic hepatitis, the necrosis is demarcated, inflammation is less, and you may find eosinophils or granulomas. Autoimmune, you can get plasma cell rosette bile duct, and you may get inclusions in CMV and so on and so forth. See, this is acute hepatitis. First of all lobules are equally affected. Changes are more near the centrizonal region, ballooning, necrosis, whatever you want to see near the centrizonal region. This area, this area, this area, all are almost equally affected, right? Whereas in drug induced, you see this sharply demarcated all around the central vein. This is a portal tract, sharply demarcated, less amount of inflammation, toxic injury, poisoning, so on and so forth. Acetaminophen, it will be in this area. You may get some this one. Okay. So slide for diagnosis. We are coming to acute. What is this? Is on biopsy. Alcoholic, okay. Right. See, we are finding almost a diffuse disease. Here you are finding large spaces, no? This one. This is a portal tract, right? It looks like that. Here it looks another portal tract. So this is away from the portal tract, maybe in centrizonal. So when it is away from portal tract, this zone 1, 2, 3, 2 and 3 are affected more. Things are away from the portal tract, right? And you're finding these large spaces. Let's go. Oh, they're all balloon cells. See? They're all nuclei. And you're seeing this, there's some brownish yellow, it looks like. There must be some cholestasis. Portal tract. Yeah, portal tract here. Inflammatory cells. Little bit of piecemeal necrosis, that's fine. But what you're finding is diffuse ballooning, right? Okay, good. And then let's go here. Yeah, there it is. They're all inflammatory cells. This is all cholestasis, ballooning. Yeah, there's large cells here, here. 1, 2, 3 nuclei in this. 1, 2, 3. These are cells, you see, 1, 2, 3 nuclei. In this balloon cells, large cells. Here also, portal tract, bile duct with this inflammation here. This is an apoptotic body here for you, right? This is a very nice example. Ballooning change with inflammation, mainly lymphocytes and cholestasis, and then of course some cells with 3 nuclei. That's good. See this? Yeah, this cholestasis here. Right? Here again. I hope that is clear. And look at this, the canaliculi can be made out here with bile inside. So canalicular, and So this is a liver biopsy showing diffuse ballooning change, perhaps more in zone 3 or centrizonal area. The cells are enlarged and many of them, some of them have 2 or 3 nuclei. There is both cellular and canalicular cholestasis with lymphocytic infiltration and few apoptosis and necrosis. And what are these cells? I don't know whether they are normoblasts or anything. They look separately. They don't look like lymphocytes with this, right? So the diagnosis is mainly a giant cell hepatitis, must be a neonate. So this is a case of neonatal hepatitis. Now let's go back. You see, this is a diffuse disease with diffuse ballooning. This is an acute hepatitis with cholestasis and all. The only pointer to neonatal hepatitis would be if you find some normoblast that was suspicious there, and of course multiple nuclei. I told you up to old age you can get 2 nuclei, no, because of the polyploidy and other thing. If you find 3 or more nuclei in an enlarged cell, it is called a giant cell or giant hepatocyte, and that is common in the neonatal period. You can get it in adults. Some viral infections do causes like that, but this is by and large in children. So this is the case of neonatal hepatitis. This is doubtful EMH. You know, here looks like a normoblast because see nucleus is smudged, and but there is cytoplasm. Lymphocyte should not have. This must be a lymphocyte. This looks like a lymphocyte, but not this. There is some change in the nuclear thing. So this is a neonatal hepatitis. Then of course the history would have been there. Clear? Any doubt? So we saw an acute hepatitis with bridging necrosis. This is a conventional acute hepatitis in a neonate. Anything else? Any doubt? Okay. None?
Questions yet, sir?
No question. Okay. We'll go to case 2. I think this will be the last case. Then we'll close. Then we'll do the rest next time. This is a 46-year-old female, fatigue for 6 months, 5 times normal serum transaminase. Alkaline phosphatase is 180. Okay. Viral serology is negative. So this is the liver biopsy. Very good course, and you're finding some lot of neutrophils. Inflammation here. You're finding fat, right? Obviously, this is the portal tract, and it's patchy disease. Very unlikely to be so acute, no? It's not the conventional type. Oh my God! Look at this inflammation. Very severe. There is fat, and look at this. You see, this is spotty necrosis. Dr. Lena was interested. Spotty. This is a small area of confluent necrosis. Not finding hepatocyte, but you're finding lymphocyte. And this is interface or
Hepatitis.
piecemeal necrosis. Here, see, the boundary is not good, but here the boundary has become irregular now, right? And this is a case, small area of confluent necrosis. That's fat. This is all in the periportal area. Oh, look at this. Quite extensive portal inflammation with, see this, piecemeal necrosis in some areas, right? See this? Oh, and there are some plasma cells look like. There is my mouse. Yeah, you see, this looks like a plasma cell. We'll go under. Yeah, this is a plasma cell. There are some plasma cells. Some are in small clusters, plasma cells, and lymphocytes, right? So there are clusters of plasma cells here. There are lymphocytes. This is a neutrophil. Yeah, the plasma cell. This is a balloon cell. And see, it's all going into this. This is an area of piecemeal necrosis, right here. Right, you see, here it is entering even the is entering even the bile ducts and also is causing some bile ductular damage. Yeah, right. There's some fat. This is a small area of confluent necrosis here, right? See this? Instead of hepatocytes, 2-3 hepatocytes, you're finding lymphocytes here. Very good. You're finding fatty change. Right? Microvesicular fatty change is seen in the periportal area. See, these are some large cells with fat perhaps, right? And finding here. And you're finding these hepatocytes arranged in small groups. Yeah, it looks like that. See, this well brought out here in this diastase pass. And you see this diastase pass positive cells here.
For cells.
With necrosis, yeah. There's some cholestasis also within the cells. Okay. This is reticulin stain. It looks like there's quite a bit of fibrosis here. You finding this? Going like this, unlikely to be here. See this? This looks like fibrosis. And look, meson trichrome also shows this. Aniline blue counter stain, yeah, it shows this. There's fibrosis, extensive. But no definite, no, there's no complete cirrhotic nodule as such, quite a bit. So, would you require any other investigations and what is your diagnosis? Anybody?
Serology.
Autoimmune hepatitis.
PBC, okay. Mandeep Singh, IgG. So, most of you think of autoimmune hepatitis. Yeah, very good. I think you are right, you know. So, this looks to be like an autoimmune hepatitis. It's in a lady, and you have to find out hypergamma-globulin, absence of cirrhosis. So there is predominantly periportal hepatitis. The earlier one we saw predominantly central. In chronic, it is usually around the portal tract. And usually you must see hypergamma-globulinemia and tissue antibodies, right? So actually there's a broad spectrum autoimmune liver disease, all of which can show similar picture. The classical autoimmune or conventional autoimmune hepatitis divided into 3 types depending on the antibody. ANA-SMA, anti-LK1, liver, kidney, microsomal antibodies and anti-SLA antibodies. Okay, ANA-SMA is the type 1 most common, that's 80%, and the 80% are women in this and 90% women in anti-LKM ones. But anyway, type 2 ones and type 3. But basically, you can see it in the older age group in this and all that. Then you have the primary biliary cirrhosis in which you do anti-mitochondrial antibody, but specifically M2 variant of anti-mitochondrial antibody. That is pathognomony. Primary sclerosing cholangitis is also included under this, but no antibodies will be present. None of them will be present, predominantly affecting the biliary tree. We'll come to that later. And ANCA may be positive. And autoimmune cholangitis when ANA and ASMA are both present. Okay, smooth muscle. Okay, and there is overlap syndrome when there is a combination of autoimmune with PBC, autoimmune with PFC, PBC with PSC, and so on so forth. Right? So when there is a combination, common is autoimmune with PBC. That's very common. Or autoimmune with PSC. So when there is a combination, it is called overlap syndrome. Otherwise, it is this. Depending on bile duct, if it is damaged more with granulomas, AMA M2 positive, it's called PBC. Primary sclerosing cholangitis, when the bile ducts are lost, it's typically you get fibrosis around bile ducts. Other markers are negative. And autoimmune, when there is predominantly lobular inflammation and periportal inflammation. So that's how you classify them with this one, right? So you can get an overlap, of course, with autoimmune with the other two. Right. So the diagnosis is all three. Before you jump into the diagnosis, clinical, serological, histology, all three before you make a diagnosis, right? You can suspect. You know, this was the earliest clinical thing for suspecting, but it had problems, you know. The moment you are a female, you get a score of 2. And the moment ALT, AST, between 1.5 and 3, you get a score of 0. Serum globulins less than 1, you get a score of 0. And this, so anyway, if you are a female, if your viral markers are negative, if you don't have a drug history, and you don't consume alcohol, and also if you don't have relatives with autoimmune disease, then your total becomes 2 plus 3, 5, 6, 7, 8, 9, 10. So it's probable autoimmune. So this is rubbish, no? Any normal lady without any of these serological abnormalities, without viral markers, without a drug history, without alcohol consumption, and other no first degree relative with autoimmune disease will become a probable AIH. So based just on clinical, it's very difficult if you use such type of classification. Anybody and everybody without any symptom also can become, but therefore it means you have to correlate all this with the clinical setting. That is the clinical finding. Then there are international, that's why they simplified this long criteria. If you have ANA or ASMA more than 140, or dilution or more than 180, or LKM more than 140, or SLA ALP positive, then you give 2, and so on and so forth, IgG and all. So in the absence of viral hepatitis, you can histology, which can be compatible with AIH or typical AIH, you make a diagnosis of probable autoimmune hepatitis or definite autoimmune hepatitis. If the total score is more than 6, it's probable autoimmune hepatitis. More than, it is actually 6, and more than 7, it could be definite. So now this, if it is more than 6 or 7, it has a very high specificity. So it based on the serology, immunoglobulins, and liver histology, which some of you have diagnosed, right? So this was one way of simplified criteria. So what are the histological features after going through all this? First, you must see interface hepatitis, which is lymphocytic or lymphoplasmacytic, infiltrating into the lobule. You must see hepatic rosettes. Then what better some people thought was, you must see emperipolysis. Nowadays they don't believe that much into it. Emperipolysis was important. Now if you see all three features, then it is typical autoimmune hepatitis, and you give 2 points in this. If you see any one of them, chronic hepatitis is lymphocyte infiltrate without all typical features, it must still be compatible in a particular clinical setting, right? If there is evidence of other diagnosis, then the features are not fitting into it. Now here we come to the thing, what is emperipolysis? Any one of you, quick, before we wind up? Anyone?
One cell inside of another cell is called
Very good, very good. So it is active penetration of one cell into another. It should be active. And the second cell should be intact. It should not burst. Okay. Phagocytosis is engulfment of a cell with lysosomal degradation. So the cell is not intact. So when the cell is not intact, it's phagocytosis. When it's intact, it is emperipelosis. Right? And there's another thing called entosis. We'll not go into it in detail. So this is emperipelosis. The first picture. The second one is phagocytosis, all dead cells. Right? This is also emperipelosis. Right? So emperipelosis is like this, intact. Entosis is different. It is engulfment of cells in a vacuolated space. You get a vacuole where, and there are other things, there are several terms nowadays. Cell in cell structures will not go into that. So emperipelosis is maybe you can see even in tumors and so on and so forth, and where it's called cannibalism. Will same cell destroying one tumor cell eating up another tumor cell, that's called cannibalism. So there are various terms, but we are interested in emperipolysis in the connotation. Usually an inflammatory cells is seen inside the hepatocyte. So you can get emperipolysis in this, like here, in many cells, you see. And so interface hepatitis, we'll go to each one of them separately. So interface hepatitis with spillover is seen in almost all cases of autoimmune hepatitis and is generally very severe, like in this case. And whenever there is a flare, it increases. So next is we saw plasma cells. In how many cases you will see plasma cells in autoimmune hepatitis? Anyone? Anyone? Over 80%, 2/3, half the cases, less than 1/3. What did Dr.
Most of them say A, sir, in more than 80% of cases.
Okay, anyway, these are plasma cells. Okay, you can do CD138, it's not necessary, but you can do C. B. What is B, Prabhakar? 2/3 of cases. Plasma cells are seen only in about 2/3 of cases. But if you see a cluster of plasma cells which is more than 5, then it is important. Plasma cells are not necessary for the diagnosis of AIH. Please remember that. Even without plasma cells, you can make a diagnosis. There's severe hepatitis, serology is positive, and so on and so forth. But if you see plasma cells, most of them are IgG positive. If they are IgM positive, think of PBC. Right? If you do IgM and they are positive, think of PBC. That's important. And of course, you can get some eosinophils, right? And defining emperipolis is also. I thought I saw somewhere. Okay, anyway, right? You can see this. The other thing is hepatic rosettes. You see, hepatic rosettes are a group of few hepatocytes joined together, or means adjacent to each other, almost forming a rosette like this. See this? This is a hepatic rosette. Please remember, in viral hepatitis, I showed you hepatocytes with a canaliculus in the middle with bile. That is called a cholestatic rosette. In autoimmune hepatitis and other form of inflammatory hepatitis, you get hepatic rosettes. But in autoimmune, you can see them in a lot more number than other diseases. So hepatic rosettes without a canaliculus in the middle. You don't see any space, no bile. So that's a hepatic rosette. Hepatic rosettes are common. Canalicular is seen in hepatitis as well as various hepatitis, as well as especially in biliary disease. So Hepatic rosates is found in about half the cases, more often than in viral hepatitis, and especially in the pediatric age group. You find them, think about him. See this? These are all hepatic rosates all over. This is a hepatic rosette. This is a hepatic rosette. This is a hepatic rosette. See? Groups of hepatocytes separated by inflammatory cells and so on and so forth. And look here, this must be an emperipolysis here within an hepatocyte. So you can see this. Look, this. This is emperipolysis. Many people think this is very important, others don't think it is important. They say in other types of hepatitis, you will not find emperipolysis. So if you find, it helps. Look, there's a plasma cell here for you. There's a plasma cell, plasma cell. If you find plasma cells, you're lucky. So emperipolysis is more common in chronic hepatitis than elsewhere. Most of them are T cells, CD8 positive. And see, you get a lot of fibrosis in this. So, and cirrhosis is very common, and but of course, if you treat, almost 60% the fibrosis will regress, and it can be missed in almost half the cases if you are not very careful. And you can get extensive necrosis in autoimmune hepatitis. This is almost pan-acinar. See, portal tracts are so close to each other. It's pan-acinar necrosis, and in fact, you can get a acute liver failure associated with autoimmune hepatitis. You can get giant cells. More than 3 nuclei in an enlarged cell is a giant cell. Please remember that. You can get it in pediatric age group or not. Okay? And it generally indicates a little poor prognosis even when you see it in adults. So there have been various scoring systems for autoimmune hepatitis. For example, you can score 0 or score 1 when there's hepatitis with mild or moderate necroinflammatory activity, with interface hepatitis, some confluent necrosis, lobular necrosis, and 2 when there are numerous plasma cells, lot of necroinflammation, and so on and so forth. So this is done. The latest recommendation which came from the International Autoimmune Hepatitis Group, lot of authors all over the world joined together in 2020. They recognized 2 forms, that is the lobular hepatitis, where the inflammation is mainly in the lobule, and the portal hepatitis, where there is mainly portal inflammation. So they recognized it can be either both or any one of them. Even then you can make autoimmune. It's likely autoimmune if there is portal lymphoplasmacytic plus any one mild interface hepatitis greater than mild lobular inflammation in the absence of histological uh, suggestion of alternative liver disease. You don't see ground glass hepatocyte, you don't see lot of fat or anything. By the way, that lady had fat. She might have had an associated fatty liver disease. We don't know if she was a diabetic or not. That is likely age. If you see lobular inflammation greater than mild lobular, that is with central lobular inflammation and necrosis, plus at least any one lymphoplasmacytic infiltrate, interface hepatitis, portal based fibrosis in the absence of any other liver disease. Then you say it's likely age. Possible means less likely if you find infiltrate without any of these above features, or with one or both of these features, any one or two, in the absence of histological features. Lobular also without any of the other 3 features, you just find some lobular inflammation. In the absence of any other reason for this, you can think it is possible. But please remember, all these are correlated with serology. If you find portal hepatitis without any of these features, no plasma cells, not much of interface hepatitis, or you find some other cause for it, they have taken drugs or whatever, or viral hepatitis markers are positive, similarly, then you think it is unlikely of AIH. So this is the latest histological criteria. So whenever you see portal hepatitis, lot of interface hepatitis with lobular, then it is likely to be or yeah, and if there are features suggestive of other liver disease, if it is not there, then it is likely to be an autoimmune hepatitis. If there is portal inflammation alone without interface hepatitis, but there is some lobular inflammation, if there is no other reason, it can still be a possible autoimmune hepatitis. So if you want to be sure, usually there are a lot of interface hepatitis, portal inflammation with plasma cells and lobular inflammation in a clinical setting. Now, if you find predominantly lobular, lot of lobular inflammation with interface hepatitis without any other reason, then definitely it is likely to be autoimmune hepatitis. Other diseases must be excluded. But if you find only lobular, very little portal, but lot of portal fibrosis, still it may be autoimmune, which may be possible if there are no other causes for this liver disease. So basically, if you find lot of inflammation in the portal tract with interface hepatitis and lobular inflammation and fibrosis, you are more strong in calling it autoimmune, provided you rule out other diseases. Please remember, lot of diseases can show similar features. You have to exclude them. So, in short, autoimmune has no pathognomonic histological features. You must know the duration of disease and have adequate clinical history. Emperipolysis and rosettes, many feel may not be 100% diagnostic. So, therefore, others will know. It is quite specific. So, if you see it, it's good. Evaluating a biopsy for AH, you must see whether there is portal hepatitis or lobular hepatitis. The portal features are like chronic hepatitis because you get interface hepatitis, lot of inflammation. Lobular is like acute hepatitis, you may see ballooning, lot of inflammation. Then, therefore, if there is lot of central lobular injury and hepatocellular necrosis, it can still be autoimmune provided other reasons are excluded. If you find lot of plasma cells and plasma cell clusters in addition to lymphocytes, think of autoimmune. And plasma cell cluster is more than 5 plasma cells. And always include the severity of fibrosis in your report. So with this, I will stop here today. It's quite late in the day and I hope you all have learned something. I'm sorry I went a little slow right in the beginning and gave some details and I hope this is of some help to all of you. Thank you. Anything? I'll stop sharing now.
For such a detailed and such an informative lecture. Any questions?
Any questions? We'll repeat it again. Some of the things means we'll go into the other diseases. I'm sorry I kept you